Assalamu alaikum. I am Dr. Abu Bakr Siddiq, Associate Professor of Medicine, Cornell Malek Medical College, Maniganj. Welcome to my presentation on COVID-19. The lecture I have made and tried to make it easily understandable for all discipline doctors as well as junior doctors and medical students, because in Bangladesh many non-clinical doctors are involved in the COVID-19 management, and also any doctors from any discipline can face COVID-19 cases in their chambers, hospital, indoor, outdoor, as well as our relatives may be affected and may seek advice from us. So, in this pandemic period, every doctors should have a reasonable idea about COVID-19. One thing I like to mention, this is a big lecture. If you do not want to see the full lecture, you can see chapter wise, the chapters given in the description with corresponding time. So let's start. So COVID-19 or coronavirus disease 2019, it is caused by SARS-CoV-2 virus, that is severe acute respiratory syndrome virus 2. It is one of the virus of the coronavirus group. Coronavirus is a group of virus and one of them is SARS-CoV-2, and it is a new virus. As we all know, it started in the Wuhan, China in 2019 and still evolving, and put the scientific authority in a puzzle, because we scientists yet has not discovered the details of COVID-19, including its pathology and management. So it has put the scientific authority in the puzzle, and it is thought that there may be some animal source of this SARS-CoV-2 virus, because the coronavirus from bat has been found similarity with the SARS-CoV-2 virus. And here is a typical graphical representation of COVID-19 cases. This is a scenario from Bangladesh. Every country has this type of graphical pattern that starts it very slowly and then gradually rises, and after few weeks then there is a sharp rise of cases. Both number of affected cases and death become exponential during this pandemic. In Bangladesh, first case was detected in March, 8th March, and first 3 cases were detected. Then the case is exponentially increasing, and till now more than 1,50,000 patients are diagnosed as COVID-19 in Bangladesh. COVID-19 is a highly infectious disease. The SARS-CoV-2 is a highly infectious virus, and one death in a community may indicate there may be around 500 people infected with this virus. And so early diagnosis is essential to limit the spread of infection by individual and group isolation. Here is a representation of different stages of COVID-19. Every pandemic has 4 stages. Stage 1 is the imported case. These are those who have traveled to a virus hit foreign countries and have come back. So initially the stage 1 is the patients only imported cases are detected, and stage 2 is the local transmission. These are those cases who have come in contact with patient who have traveled to a virus hit country. So that is the transmission of the disease from travelers to the local people. And stage 3 is the community transmission. Community transmission is when a patient is not exposed to any infected person, where one person has traveled to any of the affected country, test positive. So in this stage, any person of the community can be affected, and it cannot be actually identified the source of infection in this stage. And stage 4 is the epidemic. This is the last and worst stage where the disease takes the shape of an epidemic with no clear endpoint. And this is a graphical representation of a pandemic. This line shows the time since detection of the first case, and this line shows number of COVID-19 patient. And every country has a limit of healthcare system, and this dotted white line is indicated by the capacity of the healthcare system. And if we can take adequate precaution and slow the spread of coronavirus infection, then the graph will remain within the capacity of healthcare system. That is the blue part. With control, the number of cases will be limited and within the capacity of the healthcare system. But if we do not take precaution and cannot control the slow transmission of the virus, then there will be huge number of cases and death within short period, and that go beyond the limit of the healthcare system, and it will destroy the healthcare system of any country. Now the virology. The COVID-19 is caused by SARS-CoV-2 virus, that is severe acute respiratory syndrome coronavirus 2. It is the enveloped virus and RNA virus. This picture is showing a magnified view of the virus seen in electron microscope, and this is the diagrammatic representation of the structure of the virus. In outer portion of the virus there are many spikes. These are called S protein, spike protein, and then the red circle is the envelope, and inside there is RNA. This envelope is rapidly destroyed by alcohol and soap. So it is said repeatedly that we should wash our hand repeatedly with soap water or alcohol based solutions. The mode of transmission. Coronavirus is transmitted by mainly two modes. One is droplet and another is fomite. The droplet means small drop. When a person cough or sneeze, there are production of a lot of number of droplet that contains the virus, and if any person are in close contact with the infected people, then coughing and sneezing may cause direct droplet infection by inoculation or landing of the virus in the healthy people's nose, eyes or mouth that contains mucous membrane. So this is the direct infection. And another mode is fomite. When a person coughs and sneezes, the larger particles fall on the ground and in the nearby objects, and healthy people can be affected by this object. These are called fomites. That the our objects that can carry infection are called fomites. For example, here is a picture showing the if a person coughs or infected, the laptop may be infected either by droplet infection, or the affected person's hand may contaminate the button of the laptop. And when a healthy people use the laptop, then first carry the infection from the laptop to their hands, and when they touch their nose or mouth with this infected hand, they are ultimately get affected. So these are the main two modes of transmission. Number one, droplet, and number two is fomite. There is another mode of transmission that may occur in healthcare facility. It is called aerosol. Aerosol are droplet smaller than the usual droplet. There are some aerosol generating procedure like endotracheal intubation, nebulization. In this case, the drop size will be very small and they can float in air for several hours. So any room containing the aerosol generating procedure. In this room, health care worker should wear appropriate precaution to prevent aerosol generated infection. That includes N95 mask and appropriate PPE. Now the incubation period, that means the period between the infection, that is the virus when enters into a person's body and develops symptom. In between period, this is called incubation period. It is about 4 to 6 days on an average, but it may be 1 to 14 days. So there is a statement of quarantine that a suspected person should have a quarantine for 14 days. This is the underlying basis of 14 days quarantine, because the incubation period may be up to 14 days. And the infectious period, that means when infected people can spread the infection to other healthy people, this is called infectious period. It may range from 2 days before onset of symptoms and 10 days after onset of the symptoms. This is infectious period. So contact tracing should include the individual with contact of the infected people 2 days before the onset of symptoms and after 10 days of onset of symptoms. We are not going through details about pathology. In short, we can memorize the picture that the virus has outer S protein or spike protein that helps to attach the virus with the surface receptor, and SARS-CoV-2 has affinity for ACE2 receptor, that is angiotensin converting enzyme 2 receptor. ACE2 receptor are abundant in the respiratory tract and also other parts like heart, kidneys, gastrointestinal tract and vasculature. So when the virus binds with the ACE2 receptor with the spike protein, they gain entry into the cell, and inside the cell they replicate and produces the symptoms. So ultimately, at first it will replicate in the upper respiratory tract, then followed by lower respiratory tract, and may go to the distant organs. So ultimately it will produce the main pathology including pneumonia, ARDS, acute respiratory distress syndrome, and hypercoagulable state that may lead to thrombosis and thromboembolism, and cytokine storm with multi-organ failure. So in laboratory investigation, we will see the features of inflammation like neutrophilia, high C-reactive protein, raised ferritin, interleukin 6, and tumor necrosis factor alpha. And hypercoagulable state is evidenced by raised D dimer. This is the natural course of the disease. If a person exposed to infected people or to the virus, there may be some asymptomatic infection. It may be up to 50%. The exact data is unknown because asymptomatic patients do not seek medical care. But in different study, it shows that it may be up to 50% asymptomatic cases. But these asymptomatic cases can spread infection to the healthy people. And some people will develop symptoms. And the group of people who develop symptoms, most cases are mild, that is about 80% of cases only have upper respiratory tract symptoms like fever, sore throat or dry cough, and they usually recover spontaneously. And some patient from mild case will progress to moderate or severe case that requires hospitalization. And among these patients, some will recover with the supportive treatment that are non-critical, and some will need ICU support due to progressive disease to critical illness. And among this group of critical patient, some patient will die. The death rate is in different range in different countries. It may ranges from 0.2 to 3%. In Bangladesh, it is around 1.4%. So all patients exposed to the coronavirus will not be infected. It is not still understood clearly whether some patients remain asymptomatic and some patients develop symptom and severe disease. Here is a pyramidal representation showing the larger group only have mild symptom, that is 80% cases, that will require ambulatory care that can be managed at home, and 15% patient will develop moderate disease that requires essential care like oxygen and supportive therapy, and 5% will require ICU care. Here is a representation of different phases of coronavirus infection. Number one is viremic phase. Number second phase is the acute pneumonic phase, and third is severe phase. And there is an arbitrary line. Viremic phase may persist for about 1 week, and then start the pneumonic phase up to 2 weeks. After 2 weeks, patient may develop severe disease. Now the symptoms of COVID-19. The most common symptoms of COVID-19 is fever and dry cough. These two are most common symptoms, but there may be other features like sputum production, shortness of breath, fatigue. Some patient complain severe fatigue, and sore throat, muscle pain or myalgia. These are the symptoms of COVID-19. But there may be some non-specific symptoms like nasal congestion, headache, diarrhea, nausea and vomiting. Some patients develop anosmia, that is loss of sense of smell, and ageusia, that is loss of taste sensation. These may precede, and these may the only symptoms of COVID infection. And in elderly patient or immunocompromised patient, there may be some atypical presentation like reduced alertness, diarrhea, loss of appetite, delirium or acute confusional state in absence of fever or respiratory symptoms. We have to know the COVID-19 syndrome or disease severity, that is classified in mild, moderate, severe and critical disease, because categorization is important to determine the necessity of treatment, because treatment protocol will be a bit different in different severities, but there is considerable overlap between this group. So mild and moderate case may overlap, and moderate and severe critical case may overlap. And there are two mode of progression of the disease. Most common is most patient remains stable for about 1 week and then deteriorates. Then after 1 week they develop severe or critical disease. That is called secondary progressive. And few patients, few percentage of the patient may develop primary progressive disease, that after getting infection within few days that rapidly progress to the moderate, severe or critical disease. But the second one is most common. Patient remains stable for about 1 week, then progress to advanced disease. So here we'll see the classification, how to define the mild, moderate, severe and critical disease. This is a very simplified classification. Mild disease means patient have COVID symptom without pneumonia or hypoxia. Without pneumonia. Pneumonia means clinical or radiological pneumonia. Clinical evidence of pneumonia may include tachypnea, visible breathlessness, and chest X-ray or CT scan may reveal pneumonic consolidation. So mild disease are symptoms of COVID with without any evidence of pneumonia or hypoxia. Moderate disease is classified in this group with pneumonia but there is no hypoxia. There is clinical or radiological evidence of pneumonia but there is no hypoxia. And severe disease, this includes evidence of pneumonia plus hypoxia. And critical illness includes respiratory failure, ARDS, sepsis, septic shock or multi-organ dysfunction syndrome. So this is a simplified classification. Mild disease includes COVID symptom without pneumonia or hypoxia. Moderate disease are pneumonia but there is no hypoxia. Severe disease, there is pneumonia plus hypoxia, and critical diseases are respiratory failure and other organ failure. Here is a definition of ARDS or acute respiratory distress syndrome. First is the onset of respiratory failure will be within 1 week of a known clinical insult or new or worsening respiratory symptoms. It is characterized by impaired oxygenation, that is PaO2 by FiO2. It is called PF ratio. PF ratio. The PaO2 means partial pressure of oxygen, that is determined by arterial blood gas analysis. If PF ratio is less than 300, it is mild disease, and if it is less than 200, it is moderate, and if it is less than 100, it is severe case. Here I may talk a bit more about FiO2 because general physician may not be familiar with the term. FiO2 means fraction of oxygen in the inspired air. Fraction of oxygen in the inspired air. In the room air, we get about 20% oxygen in the atmospheric air. So the FiO2 is 20% or 0.2. So if a patient has partial oxygen pressure is 100, so PaO2 by FiO2 or PF ratio will be 100 divided by 0.2, it is 500. So PF ratio in normal people ranges from 450 to 500, but if it reduces to less than 300, it will be classified as ARDS, and according to the PF ratio, it is classified as mild, moderate or severe ARDS. And the next characteristics is chest radiology may show bilateral in most cases, but in some cases there may be unilateral opacities not fully explained by effusion, lobar or lung collapse or nodule. So one important feature is impaired oxygenation. Second feature is bilateral or unilateral opacities in the chest X-ray. And next criteria is respiratory failure not fully explained by cardiac failure or fluid overload. Objective assessment like echocardiography should be done to exclude the hydrostatic edema, that is edema from heart failure or fluid overload. So this is the criteria of ARDS. Here are in details classification. If the patient is ventilated, here is a measurement of positive and expiratory pressure to categorize the mild, moderate or severe cases. When PaO2 is not available, that is arterial blood gas analysis is not available, we can use saturation of oxygen by FiO2 ratio. If this ratio is less than 315, it suggests ARDS. And the next category of critical cases are sepsis. It is characterized by clinical features of organ dysfunction. Brain dysfunction may be characterized by altered mental status. Respiratory dysfunction may be characterized by increasing respiratory rate or decreasing saturation of oxygen or new need of more than 40% oxygen. And pulse rate is more than 130, systolic blood pressure less than 90 mm mercury, cold extremities, these are features of systemic hypoperfusion, and coagulopathy may be characterized by skin mottling or purpura. Kidney dysfunction or acute kidney injury may be characterized by reduced urinary output less than 0.5 ml per kg per hour or no urine in last 12 hours. If these features are present, then we will label it as sepsis. Also, there are some levels of sepsis. This includes platelet count less than 50,000, jaundice or hyperbilirubinemia, raised lactate level. These are the laboratory features. In children, there are different definition. We are not going through details. And coagulopathy may be characterized by increased fibrinogen and D-dimer level. If this facility are not available, we can correlate with the C-reactive protein level. So it is usually parallelly raised with the level of C-reactive protein. And APTT, activated partial thromboplastin time, and prothrombin time may be prolonged. Thrombocytopenia is usually mild, and there may be development of disseminated intravascular coagulation, that is multiple small thrombus in different parts of the body and simultaneously bleeding manifestation. It is called DIC. Here is a criteria of disseminated intravascular coagulation given by International Society of Thrombosis and Hemostasis, that includes the variable of platelet count, prothrombin time, fibrinogen, and D-dimer. Depending on the level of these parameters, we can categorize. If the score is more than 5, it is compatible with over DIC. And septic shock, along with the features of sepsis, is the patient have persistent hypotension, that is mean arterial pressure is more than less than 65 millimeter mercury, and serum lactate level more than 2 millimole per liter. It is categorized as septic shock. Mean arterial pressure means diastolic pressure plus 1/3 of the pulse pressure. 1/3 of the pulse pressure. Pulse pressure means systolic pressure minus diastolic pressure. It is called mean arterial pressure. If it is less than 65, it will be regarded as shock. Now the testing for COVID-19. So whom to test? All suspected case, that is in pandemic period, all patients with respiratory symptoms like cough and or fever should be regarded as suspected case, and this patient should be tested for COVID-19. But there is a controversy. If there is a lack of testing facility, mild case may not be tested depending on the national policy, because the severe or critical patients should be given priority for the test. So gold standard method for detecting COVID-19 is RT-PCR, that is real-time PCR, and the specimen may include upper airway specimen, lower airway specimen. Upper airway specimen, these are commonly used like nasal swab and oropharyngeal swab, and nasopharyngeal swab may be taken if the technical person is available. And the lower respiratory specimen include sputum, bronchoalveolar lavage, these may be taken. And the sputum and other lower respiratory tract specimen have high positive rate of nucleic acid and should be collected preferentially. The next investigation should include a chest radiology, and chest radiograph for all patients needing admission to the hospital, and mild cases should be judged clinically. So typically passive ground glass opacities, that is peripheral, basal and bilateral, but may be unilateral in 25% of the cases. Regarding imaging, a high resolution CT scan is preferable because in initial stages of the disease, chest X-ray is not a sensitive method, because in early disease most cases of chest X-ray will be normal. So high resolution CT scan is preferred if it is available, and typically shows bilateral ground glass opacities. Here is a X-ray showing bilateral pneumonia. Here is a consolidation and here is a consolidation, and this X-ray showing bilateral diffuse infiltration or opacity. This is a characteristics finding of ARDS. Here is a CT finding in a patient with COVID-19. Here is a ground glass opacity in the basal part, and in this X-ray there is a bilateral pneumonia. This and this. So these two tests are most important for patients with COVID-19. Number one is real-time PCR, and second is chest imaging. The other supportive investigation should include complete blood count, and it may reveal lymphopenia, leukopenia. In some patients there may be leukocytosis and thrombocytopenia. Lymphopenia with a neutrophil to lymphocyte ratio more than 3.5 is a poor prognostic sign. C-reactive protein and procalcitonin. C-reactive protein is a marker of inflammation, and procalcitonin is increased in case of bacterial infection. Other investigations: if facilities available, we should do blood culture before giving any antibiotic, liver function test, renal function test, serum ferritin, lactate dehydrogenase, D-dimer, blood sugar, and ECG if the patient has chest symptom or is more than 50 years. So among this investigation, some has prognostic value and may indicate severe disease, like serum ferritin, D-dimer, and C-reactive protein. If these levels are high and increasing, it indicates there is a high chance of disease progression and patient has a poor prognosis. Here is a data chart given by National Guideline of Bangladesh, the investigation category for mild, moderate, and severe cases. Now the high risk groups. We should detect the high risk group of the patient, because in this group patient may develop moderate, severe, or critical disease, and ultimately there is an increased chance of death. We should use three parameters to categorize the high risk group. Number one is epidemiological, number two is vital signs, and number three laboratory investigation. Epidemiological features include age more than 60 years, diabetes mellitus, cardiovascular disease like hypertension and ischemic heart disease, chronic lung disease like bronchial asthma, COPD, interstitial lung disease, chronic kidney disease, chronic liver disease, cancer, stroke, high risk pregnancy, immunosuppression by steroid or chemotherapy, HIV patient, transplant patient. This patient get immunosuppression. And then hemoglobin disorder including thalassemia and sickle cell anemia, and severe obesity. These are the epidemiological parameters of high risk group. And then vital signs include respiratory rate more than 25, heart rate more than 125, and saturation of oxygen less than 92% in room air. Laboratory parameters to classify high risk group includes D-dimer more than 1000, CRP more than 100, ferritin more than 300, absolute lymphocyte count less than 0.8, increased serum troponin I, increased lactate dehydrogenase, and CPK, creatine phosphokinase. So one epidemiological features from this group and one from vitals, all laboratory data indicates there is a high chance of disease progression. So this group should be identified and should be treated in hospital. In this part, we will see the management of COVID-19, the main part. Management of COVID-19 has different components. For example, national policies like lockdown, controlling transport both local and international, maintaining quarantine for the travelers and the suspected patients of COVID-19, and maintaining office hours including public holidays, and coordination with other departments like administration and police department, education of people with mass media, and ensure adequate facilities of treatment like hospital bed, ICU, oxygen, and healthcare workers. And personal protective measures. Every citizen of a country has his own responsibility to limit the spread of infection like social distancing and maintaining personal hygiene, especially frequent hand washing and maintaining cough etiquette. And management in hospital, we will see this part in details. Management in hospital includes the treatment of the suspected or confirmed COVID patients and infection control like personal protective equipment and disinfection in the hospitals. The hospital management starts with triage. Triage means the categorization of treatment priority of a group of patients depending on their disease severity. For COVID-19, the triage ideally should be started with phone triage. For example, if a patient becomes sick or they develop symptom of COVID, they should not come to the hospital initially. Rather, they should contact to the phone numbers in the central part like 333 or 16263. These are the central numbers for Bangladeshi peoples. Peoples from any part of Bangladesh can call to this number to get free medical advice. And other hospital like Thana Health Complex, District Hospital, and every hospital also may arrange these phone triage. So nearby people of the hospital can contact the phone. So one of the physician will receive the phone and give advice to the patient. If the management cannot be completed by phone triage, that patient may need to come to the hospital triage room. In the hospital triage room, physician will assess the patient to categorize whether it is mild, moderate, severe, or critical. In the next slide, we will see how to classify this. If the category is mild, this group should be treated in home with isolation and measures to prevent spread of infection to the others. If the patient is of moderate or severe category, they should be admitted in the hospital. And if the patient is critical after initial assessment, they will be referred to the higher center after giving the initial treatments. This is a flow chart by which we can categorize whether the patient is mild, moderate, severe, or critical. So depending on the category, the treatment protocol will vary. So we need to keep the chart in every hospital that is included in the national guideline of Bangladesh. So every hospital should have should have three zones ideally. Red zones, that in this zone COVID positive patients will be treated, and yellow zone where the suspected COVID patient will be treated, and green zone, in this zone non-COVID patient will be treated. So in the hospital triage room, the duty doctor should initially assess the patient severity. Starts with the symptoms. First ask about symptoms, whether there is fever or cough. These two are most common presentation of COVID-19, although there may be other non-specific features like sore throat, myalgia, and some atypical presentation. These should be judged individually. So if the patients do not have symptoms of COVID, they are unlikely to be COVID. They should be uh, referred to the non-COVID zone and treated accordingly. And if the patient have symptoms of COVID, they are suspected COVID. Initially, there are some definition of suspected COVID, like a patient having COVID symptom along with history of contact with travelers to the virus hit countries. But nowadays, this is not applicable probably. So in this pandemic situation, every patient with respiratory symptoms like cough with or without fever should be regarded as suspected COVID patient. And in the hospital triage room, some patient may already come with the positive report. So these two groups will be evaluated to classify mild, moderate or severe. So for this assessment, we need to consider these things. Now, number one is general look of the patient, whether patient is good looking or ill looking or distressed, whether there is any visible respiratory distress, and if possible, we do some examination like counting the respiratory rate, pulse rate, blood pressure, and heart and lungs if possible. And if there is a pulse oximeter available, we should measure the oxygen saturation and ask about the comorbidities of the patient like diabetes, high blood pressure and others. So considering this, we can classify the patients in the following categories. If there is no respiratory sign, that is no features of pneumonia like tachypnea or visible breathlessness, and examination findings normal, eating and drinking normally, and there is no major risk factors, and patient is self-caring, able to communicate. This category are mild case and do not need admission. Mild and no need of admission. This patient should be treated in the protocol of mild case. In the later slide, we will see this. And if the patient have these features of mild case, but there are associated risk factors like diabetes, high blood pressure, high risk pregnancy, chronic kidney disease, chronic liver disease, ischemic heart disease, stroke, malignancy, and immunosuppression by steroid or chemotherapy. Although these patients are mild, this group need admission due to their comorbidities. And the next category, if the patient has visible respiratory distress, respiratory rate more than 25, saturation of oxygen on air less than 94% and less than 88% in case of COPD. Patient looks unwell and clinically not heart failure or renal failure. So this category should be regarded as moderate, severe or critical illness. And this group should be admitted immediately and given oxygen challenge. Immediately give oxygen challenge 2 to 6 liter per minute via nasal cannula, because via nasal cannula we cannot give more than 6 liter of oxygen because it will be wasted and will cause the dryness of the mucosa and causing discomfort of the patient. And if there is response with oxygen after initial challenge, then the patient should be kept admitted in the isolated ward and treated with the protocol of moderate to severe case. And if the patient is not improved, there is no response with oxygen, this patient should be regarded as critical illness and they should be referred to the higher center with a facility of HD or ICU. If the patient is a mild case and no risk factors, they should be treated at home with isolation. And if mild case with risk factor, then need admission. And in addition to mild treatment case protocol, we should give thromboprophylaxis with low molecular weight heparin. So after initial assessment and treatment, if the test is already not done, they should be advised for RT-PCR, that is real-time PCR for COVID, and patient should remain in the isolation ward. And in the isolation ward, ideally every bed should be at least 6 feet distance with proper infection prevention and control measures. There is a term silent hypoxia or happy hypoxia. That means hypoxia in a patient without breathlessness. So in triage room, a patient is looking good does not always means good. There may be silent hypoxia, especially in the elderly peoples. If we suspect this type of hypoxia, then we can simply do a rapid walk test. That is, patient is asked to walk about 30 meters briskly and then again measure the oxygen saturation. If the oxygen saturation fall more than 5% from the initial value, this should be regarded as severe case and should be admitted in the hospital. And interestingly, this chest X-ray of this group of patients may show large pneumonia, but this is still not clear why this category with large pneumonia patient remain without breathlessness and without hypoxia. There is a theoretical discussion that it may be caused by pulmonary vasoconstriction. Now the treatment according to the categories. We will see the treatment categories of asymptomatic patient, mild, moderate and severe cases. So if asymptomatic patient, if the patient is tested and become positive for some reason, but they do not have any symptom, this group should be preferably treated in home with appropriate isolation and with the measures to prevent spread infection to the other people. If home isolation is not possible due to overcrowding or lack of caregiver, they should be admitted in the hospital or any designated institutional isolation may be arranged for this group. And this patient should adopt the measures to prevent spread infection to the others like physical distancing and repeated hand wash and maintaining cough etiquette, and they should be at best should contact to the hospital if any symptom develop. This is the treatment protocol of mild case. Mild case, we have previously seen that no pneumonia and no risk factor. This patient are treated in isolation, preferably home isolation, with plenty of fluid intake to reduce the hemoconcentration and subsequent chance of thromboembolism. Symptomatic treatment, for example, for temperature we can give paracetamol, for rhinorrhea we can give antihistamine, and for dry cough we can give the cough suppressant or antitacid. This group should be advised to contact hospital if they develop worsening of symptom, especially respiratory distress and altered mental status, extreme lethargy. Then the patient should contact to the hospital. The next category is mild case with risk factor, that is no pneumonia but there are risk factors like diabetes, high blood pressure, etc. This group need admission and will be treated as the mild case treatment protocol along with thromboprophylaxis with low molecular weight heparin unless contraindicated. The average dose of enoxaparin is 40 mg once daily for this group. Next group is the moderate case, that is presence of pneumonia but no hypoxia. Pneumonia means clinical or radiological pneumonia, but there is no hypoxia, that is oxygen saturation more than 94%. These are moderate case. They should be treated as mild symptomatic case protocol plus thromboprophylaxis and monitor closely for deterioration and reducing oxygen saturation. And there is controversial role of antivirals like favipiravir that is included in the national guideline of Bangladesh. In hospital, we should try to avoid nebulization as far as possible and use metered dose inhaler with volume spacer if needed, and transfer to the HD or ICU early for increasing respiratory symptoms. Next category is severe case. Severe case means presence of pneumonia plus hypoxia, that is clinical or radiological pneumonia with oxygen saturation less than 94%. This patient should be given oxygen support. In the later slide we will see different methods of oxygen delivery in COVID patients. The target saturation of oxygen therapy is 92 to 96%. Then low molecular weight heparin in therapeutic dose, it is 1 milligram per kg. So it is recommended that for severe case, that is pneumonia with hypoxia, we can give the enoxaparin in a higher dose. And proning position for 4 to 6 hours per day as much tolerated by the patient. Here is a picture showing when patient is in supine position, the greater portion of the lung remain uh, deoxygenated because of the fluid and infiltrations. We know the larger part of the lung lies posteriorly, the posteriorly 2/3 and anteriorly 1/3. So when patient is in supine position, the greater part remain deoxygenated, and when patient is in prone position, the greater part of the lung can get oxygen, and it may increase the lung capacity by 33%. So proning position should be done in every patient that requires oxygen therapy, and there may be a significant improvement in many patients. For example, if a patient saturation is 90%, with proning position it may increase up to 95, 96 and maybe higher. This group of patients should be also advised for breath holding exercise. Breath holding exercise means patient takes deep breath, hold for some times and slowly exhale. There are different methods. One of the method called 4-7-8. That is, patient take deep inspiration by counting 1 to 4, for that is for 4 seconds. Slowly inhale for 4 seconds, then hold breath for 7 seconds, and then slowly exhale for 8 seconds, that is counting 1 to 8. During exhalation, lips should be slightly closed like whistling, that is like pursed lip breathing, and this exercise should be done at least 5 times in an hour. So proning position and breath holding exercise may improve significantly in many patients. If severe case is not improved at 24 hours or deterioration, we can give steroid. In Bangladesh, methylprednisolone is commonly used. In the later slide we will see there are some recent study of dexamethasone. It was done in UK, and dexamethasone reduces mortality in patient need oxygen supplementation in COVID-19. And there is controversial role of injection remdesivir in severe case. Indications of referral: in the primary and secondary healthcare center there are unavailable some facilities of managing severe patients, so this patient may be referred to the higher center. The criteria for referral are severe and critical COVID-19 cases, acute respiratory distress syndrome, persistent oliguria even after correction of dehydration, that is a feature of acute kidney injury, multi-organ failure, active bleeding that may indicate disseminated intravascular coagulation, and any serious cardiovascular or cerebrovascular disease like myocardial infarction or stroke. But during transport we should ensure oxygen, IV fluid if needed, and other essential medications. So in primary and secondary health care center like Thana Health Complex and district hospital, we can manage the patients with saturation more than 94%, and if the saturation is less than 94% but after giving oxygen it rises up more than 94%, we can treat this patient. Beyond the limit we cannot manage these patients in primary or secondary hospitals. They should be referred to the tertiary hospitals. The next category is critical illness. About 5% of the patient may require ICU support for their critical illness. These includes respiratory failure. It may be due to ARDS or pulmonary thromboembolism, sepsis, septic shock, and multi-organ failure may occur like stroke, acute kidney injury, acute coronary syndrome. The critical illness initial part should be aimed to manage the respiratory failure with oxygen supplementation to improve the oxygen concentration. At first step, uh, the patient initially should get oxygen with nasal cannula. By nasal cannula, we can give oxygen up to 6 liter per minute. If we give more than 6 liter per minute with nasal cannula, the excess oxygen will be diluted by the atmospheric air and it will be spoiled. It will also cause dryness of the mucosa of patient and will cause discomfort. The next step, if by nasal cannula, after giving oxygen by nasal cannula, oxygen saturation is not improved, then the next step is use of simple face mask. This is a simple face mask that can deliver up to 10 liter per minute oxygen. If still no improvement, the next step is non-rebreather mask. It is called non-rebreather mask because there is a special reservoir bag. In this bag is connected to the central oxygen supply and it is highly concentrated 100% oxygen, and when patient inhale, the high concentrated oxygen go from this bag to the patient's lung, and there is a bulb, one-way bulb. Oxygen can go from this bag to the patient, but when the patient exhale, this carbon dioxide containing air cannot come back to this reservoir bag because the one-way bulb. Rather, the carbon dioxide containing air is exhaled by two vent or window by the side of the mask. One of the important things regarding non-rebreather mask is it cannot be used for long time, and once it used, it should be observed by a healthcare worker because if the bag become empty for some reasons, it may be dangerous for the patient. Non-rebreather mask can supply oxygen up to 15 liter per minute. If still oxygenation is not improved, the next step is high flow nasal cannula. High flow nasal cannula, it is a special device. It is a special device that is connected to the central oxygen supply. In this device, oxygen is modified with addition of humidity and temperature, and this oxygen humidified and giving temperature, this oxygen is delivered through a special wide bore cannula. It can deliver up to 70 liter oxygen per minute. If we give oxygen through high flow nasal cannula, the initial oxygen concentration should be at least 20 liter. If we give oxygen less than 20 liter through this nasal cannula, it will not work. The high flow nasal cannula is not available widely. There are only few nasal cannula, high flow nasal cannula in Bangladesh. If the oxygenation is still not improved, the next step is non-invasive ventilation. Non-invasive ventilation like CPAP or BiPAP. CPAP means continuous positive airway pressure and BiPAP means bilevel positive airway pressure. Continuous positive airway pressure called continuous because it gives similar pressure both in inspiration and expiration, and bilevel positive airway pressure, it is called bilevel because inspiratory pressure is higher than the expiratory pressure, and it is given by a tight fitting face mask. In this picture we can see the inspiratory pressure is 15 centimeter water and expiratory pressure. PEEP means positive end expiratory pressure. It is 10 centimeter water. As these are different, it is a BiPAP therapy. If all of the measures fail, the last step to improve the oxygenation is invasive ventilation with endotracheal intubation, but the outcome of invasive ventilation is very poor. The mortality is very high in this group and it may ranges from 50 to 90%. So these are the different steps of oxygen therapy in patients with COVID-19. The chart already you have discussed. We are not going through details of mechanical ventilation. Then thromboprophylaxis should be given, and in the later slide we will see details of the anticoagulation. Other treatment for critical illness include steroid like methylprednisolone or dexamethasone. For any suspected infection we can give broad spectrum antibiotic, and for hypotension we can give norepinephrine. Here dopamine and dobutamine should be avoided because they may cause vasoconstriction, including pulmonary vasoconstriction, and aggravate the hypoxia. Maintain eubulimia to avoid fluid overload. There is controversial role of injection remdesivir, and some other treatment may be given in cytokine storm like tocilizumab and convalescent plasma therapy. These are all also controversial treatment. WHO does not recommend using it outside the clinical trial. So indications of plasma therapy includes severe or critical early stage of disease with rapid progression. That is, a patient develop COVID symptom and very quickly within few days they develop severe or critical disease. These are eligible for convalescent plasma therapy. Like all other transfusion, there may be some adverse effect like circulatory overload, transfusion related lung injury, allergic reaction. Monitoring for severe to critical ill patient. If facilities are available, some tests should be done daily like complete blood count, procalcitonin, C-reactive protein, interleukin 6, brain natriuretic peptide, troponin I, ferritin, D-dimer, magnesium. CRP and ferritin are good biomarker of disease severity. Then blood glucose monitoring, especially for diabetic patient and patient on steroid, because steroid may increase the blood glucose level. Monitor QT interval because QT prolongation may cause ventricular arrhythmia. Chest X-ray and echocardiography may be done. Patients sometimes develop severe cardiomyopathy or myocarditis that can be evaluated by echocardiography. The recent study of dexamethasone is done in UK called Recovery Trial, where a large number of patients, more than 2000 patients, were in the study group and more than 4000 patients were in control group, and it showed that dexamethasone reduced death by 1/3 in ventilated patients and 1/5 in other patients receiving oxygen only, but there is no benefit among those patients who did not require respiratory support. So this should be given only in patients needing respiratory support. Now we'll see some details about anticoagulation in COVID-19. Indications includes all patients with moderate to severe COVID-19. Contraindications includes platelet count less than 25,000, active bleeding, high bleeding risk like hemorrhagic stroke, untreated inherited or acquired bleeding disorders, liver failure with INR more than 2, persistent severe hypertension, within 12 hours of any invasive procedure like surgery or lumbar puncture. Baseline and daily investigation should be done in this group of patients who are given anticoagulation. Complete blood count, prothrombin time, activated partial thromboplastin time, D-dimer and C-reactive protein. If a patient is already on oral anticoagulation, they should be switched to low molecular weight heparin or unfractionated heparin on admission. There is a guideline regarding dose of anticoagulation. We will simplify it by seeing main three categories. Number one is low risk. Low risk are categorized if the D-dimer is less than 1000 and no suspicion of pulmonary embolism or deep vein thrombosis. These are low risk group. In this group, we will usually give enoxaparin 40 mg once daily. And if the D-dimer is high, increasing oxygen requirement, these are high risk group and they should be given double dose of enoxaparin, that is 40 mg twice daily. In this group, after discharge from the hospital, we should consider extended thromboprophylaxis. In Bangladesh, it is used rivaroxaban 10 mg once daily for 4 weeks. Another category is confirmed or high suspicion of venous thromboembolism. This patient should be given again a higher dose of enoxaparin, that is 1 mg per kg twice daily. In this group, one discharge oral anticoagulant, direct oral anticoagulant like rivaroxaban 20 mg once daily for 3 to 6 months. If the creatinine clearance rate is less than 30, we can reduce the dose because it may increase the chance of bleeding. Low molecular weight versus direct oral anticoagulant for thromboprophylaxis. Parenteral anticoagulation is preferred method of thromboprophylaxis in patient with COVID-19 because the concern of excess bleeding in seriously ill patient, drug-drug interaction with off-label COVID-19 therapies. Heparin has some theoretical additional benefit, like it has some anti-inflammatory effect and it may block viral attachment by binding to the spike protein of SARS-CoV-2 virus. Low molecular weight versus unfractionated heparin. Low molecular weight heparin is preferred over unfractionated heparin for thromboprophylaxis to reduce the contact with healthcare worker, but unfractionated heparin may be preferred in patient with high risk of bleeding and if CCR less than 30, we can use this. Management of coagulopathy. If only abnormal coagulation result but there is no active bleeding, treatment modification is not necessary. But if there is major bleeding, anticoagulation should be stopped and give fresh frozen plasma empirically and red blood cell if necessary. It will be followed by blood test like prothrombin time or INR, fibrinogen level and platelet count, and should be managed accordingly. If platelet less than 30,000, we can give a pull-up platelet transfusion. Here is an important message regarding DIC. Tranexamic acid should not be used in case of DIC because the recovery of the DIC is dependent on endogenous fibrinolysis, that is breaking down of the disseminated thrombi in different parts. This process will be inhibited by tranexamic acid, so it is contraindicated in DIC. And heparin may be considered if there is overt thromboembolism or organ failure due to clot. Some other drugs are tried in different countries and different trials. Chloroquine and hydroxychloroquine, already it is shown that mortality is increased with chloroquine and hydroxychloroquine with or without azithromycin. And azithromycin also has no proven benefit in COVID cases unless there is secondary infection. Ivermectin and doxycycline, anecdotal report of some benefit but not proven by any clinical trial. Regarding pregnancy, we do not have any detailed data because most clinical trial to date have excluded pregnant and lactating women. Timing of delivery should be dictated by obstetric indications rather than maternal diagnosis of COVID-19. If in third trimester, attempt to postpone delivery until a negative test result. COVID-19 in pregnancy is not an indication of early delivery. There is no evidence of vertical transmission. Regarding breastfeeding, SARS-CoV-2 has not been isolated from breast milk, so decision should be taken by mother, family member as well as physician, because there is a chance of transmission of virus to the infant. If the woman choose to room in with their infant and feed them, they should practice good hand hygiene, wear a face mask to prevent transmission of the virus to the infant by respiratory droplet. If the mother do not wish to breastfeed and want temporary separation from the infant to prevent spread of infection, they should express their breast milk ideally with a dedicated pump and practice good hand hygiene before and after pumping. Consider having a healthy person to feed the infant. There are some acute cardiac emergency may occur in COVID-19 like acute coronary syndrome, myocarditis and arrhythmia. They should be treated in consultation with cardiologist. In acute coronary syndrome in COVID-19, conservative management is preferred and percutaneous coronary intervention can be done if a COVID dedicated cath lab is available. Some patients may develop acute kidney injury that may require renal replacement therapy like dialysis. These are the discharge criteria if a patient admitted in hospital when they will be discharged. The criteria includes afebrile for 3 or more days without paracetamol and significant improvement of respiratory symptoms like cough and shortness of breath for at least 3 days. Criteria for discontinuation of transmission based precaution. For asymptomatic patient, 10 days after the test positive, patient can discontinue the transmission based precaution including returning to workplace, and repeat PCR test is not necessary. That was done in earlier part of the pandemic, that a patient was declared cured after two subsequent PCR negative 24 hours apart, but nowadays repeat test is not necessary. Patient can go back to their work and discontinue transmission based precaution after the 10 days of the test is positive. And for symptomatic patient, they should be afebrile for more than 3 days without paracetamol and significant improvement of respiratory symptoms, and at least 10 days have passed after symptoms onset. COVID-19 vaccine, there are lot of companies in the world trying to manufacture these vaccines. The most advanced one is Chadox 1 NCOV-19, that is developing some companies in UK, that probably has started phase 2-3 trial in England and Brazil. The result is not till published. How long will the coronavirus pandemic last? We cannot predict with anything for how long it will persist, but there are some hypotheses. The expert has found some similarity of COVID-19 with Spanish flu in 1918, and they suggest that it may persist for 18 to 24 months. The pandemic likely won't be halted until 60 to 70% become immune, either naturally or with vaccine. So the possible future courses, there may be 3 type of scenario. Scenario 1, peak and valley, that is repetitive smaller wave. Second scenario, fall peak, that is second wave may be larger than the first wave. In Spanish flu, most people died from this second wave. And third scenario is slow burn, that is small number of cases may persist throughout the years. This part is regarding infection control. Infection control, for this we should consider from where we can get infection. Source of infection may be person like patient, healthcare worker, visitor or community members. And environmental things also may be a source of infection like surface, medical device, dust or decaying debris. So ensure safety of patient, healthcare and personnel and environment. It is studied for the surface viability of coronavirus. It is found that on plastic and stainless steel it persists for a long time. It may be 2 to 3 days and even more. And on cardboard it can persist for 24 hours. On copper it can persist for 4 hours and in air it can persist for 3 hours. Infection prevention and control precaution categories include standard precaution that applies to all patients care and transmission based precaution based on organism and mode of transmission. Contact precaution, that every patient are potentially infected, so before seeing any patient we should wear gloves or gown at all times in the patient room, and gloves and gown should be removed before leaving the patient's room. Use dedicated non-critical items like stethoscope, thermometer, BP machine if possible. If unable to do so, then disinfect each item properly after each use. Transmission based precaution includes droplet precaution and airborne precaution. For droplet precaution, we should wear a surgical mask along with other PPE. And airborne precaution, for procedure that can lead to aerosol production. In this case, we should use airborne protection. In this case, we should wear N95 or equivalent mask or respirator along with other parts of PPE. These are the aerosol generating procedure, endotracheal intubation, extubation and related procedure. Open suctioning of the respiratory tract, tracheostomy, bronchoscopy, upper ENT airway procedure that involves suctioning, upper GI endoscopy, nasogastric tube insertion or removal, surgery or postpartum procedure, some dental procedure like high speed drilling and scaling, non-invasive ventilation and nebulization, although it is controversial. These are the aerosol generating procedure. In this area of aerosol generating procedure, we should take precaution for airborne infection including N95 or equivalent mask. Some discussion about personal protective equipment. Personal protective equipment includes not only gown, but along with gown we should use the appropriate mask. Depending on the scenario, we can use the surgical mask or N95 or equivalent mask, then a goggles, face shield, gloves and show cover. These are the part of personal protective equipment. N95 or equivalent mask. There are some procedure to identify the real mask or fake mask. This is a cut picture of N95 mask that contain 6 layers, 5 or 6 layers. The main layer is made up of a special filter that is called melt blown polypropylene. If we give if we try to burn this middle layer, it will shed, it will not burn like a paper. If it burns like a paper, it is a fake mask. Here are the steps of PPE donning. This chart is given by CDC, Center for Disease Control. At first we should wear gown, then mask or respirator, then goggles or face shield, and then gloves. Here are some details steps of donning. We are not going through in details. Here are the PPE doffing stage. Doffing stage is more important because the healthcare workers are mostly infected during the doffing period. During doffing, at first we should remove the outer gloves. If we use two gloves, outer gloves should be removed without touching inside, and then goggles or face shield. Then we remove the gown, and then mask or respirator. Then wash hands or use alcohol based hand sanitizer, and take shower as early as possible. And between every steps we should practice hand hygiene, like with alcohol based hand sanitizer or washing with soap and water. Here are some detailed steps of doffing. We are not going through in details. So personal protective measures should be adopted by every citizen of a country to limit the spread of infection, because we cannot be sure for how long it will persist. So our self protection should be the most priority. We should stay home unless absolutely necessary. We should not go outside, and if we go outside we should use a appropriate mask appropriately, covering the nose and face, and maintaining social distance at least 6 feet or 2 meter, because the droplets from coughing and sneezing can go up to 6 feet. Maintain cough etiquette, like cover your nose and face with tissue if available. If tissue is not available, use bent elbow instead of palm before coughing or sneezing. And if we use tissue, it should be put in the bin immediately and followed by hand wash. We should wash our hand frequently. This is the most important part, because the most infection are spread through the hand, and when hands are contaminated, people touch their nose, mouth or eyes with the contaminated hand, they get infected. So we should practice repeated hand washing for at least 20 seconds. We should wash our hand once at least every 2 to 3 hours, and after touching anything that may be suspicious of infection. And do not touch our face. This is called a T-zone. We should not touch our T-zone, the eye, nose and mouth. This contain mucous membrane, and we should not touch T-zone until our hands are clean. Even our hands are clean, we should practice not to touch our T-zone. And to boost immunity, exercise is advised. If possible, we will do some exercise daily, and take Healthy foods including some fresh fruits and vegetables that will increase the immunity, and take adequate sleep for at least 6 to 8 hours per day. These are the personal protective measures that should be adopted by every individuals of a country to limit the spread of infection. Now the summary of the lecture. Virology. The COVID-19 is caused by SARS-CoV-2 virus, that is severe acute respiratory syndrome coronavirus 2. It is an RNA virus, and spike protein, that is S protein, helps in the main pathology. The virus binds easily to the cells containing ACE2 receptor that are most abundant in the lung, heart, vessels, and kidney. Clinical feature. Most common features are fever and cough, but there may be other features like sore throat, sputum production, anosmia, and some atypical presentation like reduced alertness in absence of fever, especially in elderly people. Severity classification include mild case, that is no pneumonia, no hypoxia; moderate case, presence of pneumonia but there is no hypoxia; severe case, pneumonia plus hypoxia; and critical illness, pneumonia plus hypoxia plus respiratory failure, sepsis, septic shock, or multi-organ dysfunction syndrome. Investigations include the real-time PCR for all patients, and next is chest imaging, either chest X-ray or CT scan, high resolution CT scan, and complete blood count, C-reactive protein, liver function test, renal function test, serum ferritin, and D-dimer. Management includes symptomatic management like paracetamol, antihistamine, antitussive, and if the patient develops hypoxia, then we will give oxygen. The moderate to severe case should be given thromboprophylaxis with low molecular weight heparin, and if there is suspected infection, bacterial infection, we can use antibiotic, and steroid may be used like methylprednisolone or dexamethasone in moderate to severe patients. And there are some controversial role of antiviral like oral favipiravir and injection remdesivir. Regarding infection control, we should take some standard precaution before seeing any patient, and transmission based precaution like droplet precaution. For that we can use the PPE including the surgical mask, and airborne precaution. In that case we should wear the N95 or equivalent mask along with the other components of the PPE. These are all about COVID-19. Thank you all.